Good afternoon, everyone. Hope people are joining in. We have 17 participants right now. Uh, so once again, thank you so much for the joining for the last day of this program. Hectic 5 days. Today we have reached the fifth day of the program, and thank you so much for keeping the spirits up till the fifth day. Today we have two small topics, one on grief and bereavement and one on empathy. Both are included in the second year MBBS curriculum. So we'll have a demonstration about that short lecture. And today we have Dr. Seema as our faculty. Dr. Seema is a psychiatrist trained in palliative care, did her post-graduation from Cardiff University. And currently she is heading the Department of Education and Research in Karnashaya, Bangalore. Uh, I can't think of any other person who can talk about grief and bereavement than Seema. So thank you so much, Seema, for agreeing. Like she has her own department running there, so you can imagine the schedule. But thank you so much for agreeing to be part of this program for last few days and specifically today. Welcome, Seema.
Thank you so much, Sri, because you have two back-to-back sessions with me. So I hope I don't bore the participants, post-lunch session and the same person speaking to relatively subjects would be, I hope it's worthwhile for all of you. But again, thank you so much for asking me to be part of this. Yeah, and I would like everybody, I'd like to keep this as interactive as possible. And if you could all have your whoever videos on, that would be very nice. So I hope my screen is visible.
Yes, it is.
You can see, right? It's in the slideshow mode.
Yes, yes.
Thank you so much. So I'll be talking briefly about grief and bereavement and, understand the concept of loss, grief, bereavement. What are the stages and what's the difference between adaptive and maladaptive grief and how do we manage it? What are the basic things that we, not too much in detail, but what are the basic things that we need to keep in mind? So I'll be briefly running through this. And how much time have I got, Sri, for this, Sri Devi?
You have 40 minutes for grief and again, 40 minutes for grief.
Okay. Thank you so much.
240.
Yeah. So when we talk about grief, right? Grief for most of the people who are grieving, it looks somewhat like this, it is something like everything is there, right? But somewhere the color has been lost. Okay, there is the flower, there is the leaves, and there is the water, but somewhere everything seems very dull. It's like a heavy gray blanket spread over everything else in the life. It erases color, obscures details, and makes it very difficult for the person who's going through the grief to actually bear or put up with it. Everything seems muted and colorless. That's what grief does to most of us, isn't it? I'm sure all of us at some point or the other have experienced some form or the other of grief. And this is the water body in Karunashraya, which is a hospice in Bangalore. So we have this beautiful water lily blooming there. And this is a photo from that. Okay, so when we look at it, when life ebbs away and the color fades away, what happens to people? Like, let's take a small example of Mrs. Sarita. She was one of the patients who had come to us. Her name is changed, of course. She is a 30-year-old IT professional, married, has 2 children, aged 10 and 8 years, recently promoted in her job, and they were planning to move to Singapore. Her husband is also an IT professional. He also had got a job in Singapore. So she noticed a small lump in her breast. She was investigated, and the full workup revealed that she had had a breast cancer that had spread to the bones, as well as there was lung metastasis, as well as skeletal mets with this. And she was told that it was incurable, but treatment options were available to control it. Now imagine what happens to Sarita and to Sudhakar and to the 2 children. Can you tell me what could all be the emotions and the issues that they are going to face? You can either unmute and talk, or you could put it up in the chat. Either way.
she'll be very angry why this has to happen to me.
Absolutely. Yes.
What did I do wrong, or what past sins are there?
Correct. Why did this happen to me? What did I do wrong? Anybody else? Okay, I can see a lot of
Hopelessness about future.
future
So
is, yes,
very
absolutely.
bleak. Yeah.
Yes. Loss of hope, denial, anger, fear, depression. Absolutely. You've told everything that is there to be told, right? There's another new message coming. Children's future, care of a family. Absolutely. What is this that she is experiencing? This can't be happening to me. What am I going to do? Yeah, lot of treatment options are coming up. I'm so confused. What about the job? She's just recently been promoted, planning on a new life, right? In Singapore, promoted in the job, doing so well. She's crying, she's distraught, very anxious, she has palpitations. It's not only Sarita, isn't it? What's happening to Sudhakar? If only she had told me earlier when she noticed the small lump, right? Why did she keep it a secret? The doctor did not do anything. We went to the GP. He took so long, right? Before he sent us for any investigations, right? There's anger. He's unable to concentrate on work. He's angry and he is irritable. Two people going through similar circumstances, but the emotions are different here, isn't it? Right? So when we look at grief and bereavement, there are some things that we need to understand. There is a sense of loss, there is grief, there is bereavement, what we call it, there is mourning. Anybody would like to tell me what each of these are? Yeah. They are similar, they are different.
They look very similar. Come to think of it. Yeah.
Yes, they look very similar, isn't it? Yes, absolutely.
Loss means somebody has died.
Which one? Loss. Okay.
Loss.
Hmm.
Grief is a feeling of sadness.
Hmm.
And bereavement and mourning is you are feeling sad for the loss.
Hmm.
And bereavement, I'm not sure how to say that.
Hmm. Okay, Madhu says interrelated. Oh, yeah, they're definitely interrelated. It's a continuum of events. Yes, but we have to be very clear about the terminologies, right? One of the things to understand any phenomenon is to know what that phenomena is. These are all phenomena that occurs in our minds and what we experience, isn't it? So when we look at loss, what happens about the job for Sarita? What happened about the job? She would have lost her job, right? Because of the cancer and the treatment. So loss, what is happening? It's not clicking. Okay. So loss is when something that we are attached to or that is valuable to us is taken away from us, we experience a loss. It could be loss of money, it could be loss of position, it could be loss of job, it could be loss of a person, or it could be loss of our health, right? Losses can be multiple. It could be due to death, or it could be non-death losses also, right? So that is loss. What is grief? Grief is an distressing emotional response to any loss. Yeah, so that is what grief is, right? So this loss could be loss of a relationship. Even divorce is a loss, right? Even after divorce or a breakup of a relationship, people can experience grief. So grief is a distressing emotional response to any loss. When we talk about bereavement, it is a state of loss, which is it is due to the loss. It is the loss of a loved one, right? The emotional reactions that you undergo when somebody close to you or whom you love dies. That is bereavement. And when we talk about mourning, it is Okay? It is a process of adaptation, which is cultural, social, and religiously accepted way of expressing your loss, especially after the death of a loved one, right? So loss is when something valuable is taken away from us. Grief is the response to this loss. Bereavement is the loss of a loved one through death. Okay, and mourning is a process of adaptation through which it's a culturally accepted public display of our grief, right? So these concepts have to be very clear. So what are the losses in Sarita's case? In Sarita, it was about her self-image because she would need to get operated. It's about a functional status. It's about, doing what she'll no longer be able to do what she likes. It's about loss of identity, work, role, her whole future. And probably she has been planning to progress in her career, everything. There are multiple losses that happens. Some losses are direct effect of the cancer, some are indirect effect of the cancer. And losses happen not only for Sarita, but for Sudhakar and for the children also, right? The loss of the role of the mother. Mother may not be able to fulfill what she was doing as well as she was doing before. Family roles may change. Financial stability of the whole family gets disturbed, right? And their shared past and their shared present and the shared future, everything is disrupted because of this one illness. So if you can see, you get a family that is dealing with multiple losses and who are going through different individual phases of grief they go through, right? So manifestations of generally of grief is many. It could be, people may say that I'm sad, I'm angry, I'm depressed, I feel a lot of guilt, or I'm fatigued emotionally, or they might express this loss telling I'm not able to sleep, I have no hunger, my heart is beating very fast all the time, I have no energy to do anything. There is a tightness in the throat all the time. So it could be physical symptoms, it could be emotional. Some people, end up drinking. I'm sure we've all seen the movie Devdas, isn't it? Loss of a relationship, and he goes and starts to drink. So some manifestations of grief can be behavioral, right? There might be crying, there might be substance abuse, they might attempt even suicidal behavior, and the cognitive symptoms are there. There could be spiritual anger at God, belief in the God could be shaken up, loss of faith, etc. So manifestations of grief could come in multiple ways, and it is important for us to know that what the patient is experiencing, the family is experiencing, so that we are able to sort out what is affecting them. So have you heard of Elizabeth Kubler-Ross? Yeah? Anybody?
Yes.
Some of you have written. Yeah? Yes. Okay.
She's done a lot of work on death.
Yeah, on death and dying, right? And many of you have put in the chat box, right? Denial, anger, etc. Right? So she was the one who coined the different stages of grief. What are the stages that people go through? Model for bereavement, okay. Yeah, so she is the one who spoke about the grief cycle, right? So what do people go through when there is grief? They go through different stages. One, we deny, dabda we call it, denial, anger, bargaining, depression, before finally coming to a stage of acceptance. Okay, and remember this, when we talk about denial, it is the first reaction that people immediately, when they are given a bad news, I'm sure, they go into a shock. No, this is not happening to me. There is something wrong with the report. Okay, maybe we'll go to some other doctor and show. Maybe we do a biopsy one other time. Are you sure what you've told me is correct? So initial reactions, what comes in is what we call as denial. They refuse to believe that a loss has occurred, right? And the first aspect of denial, what they experience, is always an adaptive mechanism. It is because the emotional surge that comes in, okay, the body and the mind is not able to handle it. So people go into denial at that point in time, and slowly over a period of time, people are able to process their grief and they're able to accept the loss and process their grief. So denial in the beginning is very adaptive as long as it does not interfere with the treatment plans. And sometimes we have to give space for patients to express their denial, to express their anger before they move on to the next stage. Now, the other expressions that comes in is anger. Why me? It's not fair. Why has God punished me like this? You know, the anger could be at self, anger could be at those around the person, like the relatives, or the anger could be at the God, or it could be at doctors. If you see, most of the reactions when a death occurs, patients and the caregivers become very angry, isn't it? It's all grief related anger. So we have to learn how to handle this anger in the caregivers. And anger sometimes can be very constructive. It helps, it gives a sense of control to the person who's expressing the anger, and it can mask grief. So what you see is anger, but what the patient actually or the relative is actually feeling is grief. Okay, so if we are able to navigate that emotion, then we will be able to help the caregivers and the patients deal with the anger. The next stage that they go into is bargaining. Okay, and I'm sure most of the patients who come to us, you will find some of them in this stage. When you tell them treatment is not possible, is there no treatment in India? Can we go for alternate systems of medicine? I mean, we are ready to willing to spend money, but is there any special treatment that you could give? They keep asking you, isn't it? That's a phase of bargaining where, the hope is gone. There is a extreme loss. Then they want to bargain with you. Some people bargain with the doctors. Some people bargain with God so as to be able to deal with this, right? And guilt is often, sometimes many of them will sort of say that, if I get well, I will leave eating a specific type of food, or I'll go to the temple, or I'll do this sort of puja. So lot of issues can happen when patients are going into this stage of bargaining. And whenever we assess any patients, when we talk to any patient, it's important to see which stage of grief patient is or the family member is in. And then finally, there is a stage of depression. And here, clinical depression that we're talking about, it is a sense of sadness that this has happened, and it's also a very adaptive response. And finally, they reach a stage of acceptance. Now I have this disease, that nothing can about it. How am I going to learn to live with this particular loss? Okay, so when they reach the stage of acceptance, as we call it, they create a new normal for themselves. See, things are not going to be, Sarita will not be able to go back to work the way she did before. She might have to go for chemotherapies in between. She may have to restrict her activities. So she will do that and learn to live a life of new normal. So these are the 5 commonly seen stages in grief. But one thing that we have to remember is there is no one size that will fit everyone. Each individual goes through it's like a roller coaster ride, they have their own ups and downs in the grief cycle. They can flip in and out of different grief stages. For example, if a patient is accepting today, after 1 week or 2, when they come back to you, they might have gone back to the bargaining stage. So it is not necessary that patients, once they reach acceptance, may remain in acceptance forever. So that's something that we need to keep in mind. And second thing, the most important thing is, it is every journey of a patient with chronic illness is filled with loss. Simple example, today patient is undergoing chemotherapy. There is a complication, the chemotherapy may stop, patient will experience grief for the loss of chemotherapy. Tomorrow, right now, there is only lung and bone skeletal metastasis. Tomorrow, the metastasis to brain can occur, and the patient will then experience grief for that. So for each loss that the patient is experiencing, the patient and the family will go through grief. So you can imagine how difficult this journey of a patient with a chronic illness is when there are repeated losses occurring, right? Any questions so far in this? Any comments or any questions? Five stages of grief is clear.
Yes, ma'am.
Yeah, so that's another model of grief that they say that it is the dual process model of grief, where Straub and Stewart had said this, that people will oscillate between loss-oriented and restoration-oriented responses. Their everyday life experience, keeps moving between loss oriented, where they think about the person that they have lost. There are these negative emotions that come in. There is crying, there is avoidance, denial, etc. that can occur. And then there is the restoration oriented responses. That is, they start living their normal day-to-day life. They start watching movies, they start doing things that they were doing previously, and they start going out of the house. So people oscillate between one response that is loss oriented and the restoration oriented. In the initial few days, weeks of grief, it is more of loss oriented response. But as the days progress, they start moving towards the restoration oriented responses. So this is another model that they say. And when we talk about adaptive grief, what we know is that adaptive grief is self-limiting. Okay, symptoms will gradually diminish, but it will not go away. There is no complete resolution. There is no getting over with. We say, no, it's all right, you will get over with it. That's never, no getting over with the loss. That sadness, longing, memories will remain. There will be acceptance of the death would be there, and people will learn to live with the loss. It becomes a part of their life. They will never get over it. And generally, they say between 6 to 12 months, they reach that stage of acceptance, and things resolve and people start functioning. You can wait up till 12 months following the death to allow the person to give the time to adapt to the loss. Remember, there are no specific rules about grieving. It is a very individualistic process, and no two people's grief are alike. Sarita will deal in one way, Sudhakar will have another way of dealing with the grief. And it is each individual who walks that journey on their own. So anything, when we label it as not adaptive, we have to keep all this in mind. So there are generally three types of grievers, as we call it. One is what we call as intuitive griever, instrumental griever, and most of them, and the third style is called the blended grieving style. When we talk about intuitive grieving styles, here it's more of emotional reactions to grief that we see. Some people tend to cry more, talk more about the loss, express their feelings, say how sad or how distressed they are. The others, the instrumental grievers, are those who don't talk about their emotions. They go mechanically, they keep themselves very busy, they start working harder than normal, right? They adapt to the grief by doing activities that will keep them continuously engaged, so that they don't have to deal with the emotions. So most of the people who are grieving are blended grievers who use both the style in grieving. So when do we say a grief is maladaptive? when it extends for a longer period of time, when the symptoms are so intense that, you know, patients are not able, I mean, it interferes with their day-to-day functioning. At that time, we call it as complicated grief. And patients who are experiencing grief are more likely to express increased incidence of depressive disorders, anxiety disorders, psychotic disorders, and post-traumatic stress disorders. So psychiatric issues are also higher in those patients who are going through the grief process. But remember, 80% of the people will recover without any extra help during the grief. Around 15% will 10 to 15% will experience complicated grief, and very few, less than 5%, will go into psychiatric issues, will develop due to the grief. So 80% of the normal population will manage the grief on their own without any help. There are, however, different types of complicated grief as we see. One is what we call as chronic grief, where returning to normal activities become very difficult for the caregivers or the loved ones, and they continue to grieve for an extended period of time than what is considered to be normal. There is an inhibited or delayed grief, that is, in certain circumstances, people, the loved ones, are not able to express their grief. For example, when there is small children involved and the one parent is lost, the other parent has to look after the children and fulfill both the roles. At that point, the bereaved parent may not have intentionally postponed that experience of the grief, you know, because of the and choose that instrumental way of grieving, doing things for the family rather than experiencing the pain. So that could be this delayed grief. There is something called as disenfranchised, exaggerated, as well as traumatic grief. I'm sure all these are available for you to read. The next question I wanted to ask us is it possible for us to predict who will go in for complicated grief? From your understanding, is it easy to predict or not? Anyone?
Yes, madam. Maybe type of personality. Usually, type A personality people are more anxious in compared to.
So one is the personality of that individual may help you predict. Okay, excellent. Anything else?
If they have good support systems, then likely that
Yes.
Grief may not be so prolonged. If they don't have good support systems, then grief may be prolonged.
Absolutely. Thank you so much for that. Anything else that you can think of? Previous history, Feba says previous history of depression, anxiety. Absolutely. Anybody with a previous history of a psychiatric illness might be more prone for a complicated grief. Yes.
Madam, based on their financial stability at that time, whenever they are facing these issues.
Yes. Financial stability, that can contribute to whether the person copes or doesn't cope. What is the other one in the chat? Family support, absolutely. Most important, the extent of family support. Is there anything in the way a person has died that can contribute to the grief process? Any idea?
It's a sudden, unexpected loss. Maybe.
Sudden, unexpected loss. Younger age, absolutely. Yeah, so there are, isn't it? From you, okay, one more comment on sudden death, absolutely. Unexpected accident, yes, unexpected deaths, right, where there is no closure, isn't it? Right? So the other day I was just reading about somewhere in Florida, I think in that in the universe, some roller coaster ride, a 19-year-old or a 20-year-old young adult, 6 foot tall guy, sat in those roller coaster ride, got ejected out of the seat by accident and passed on. So I was just, the first thought that struck me was, here the family would be totally unprepared, isn't it? With an illness, you are more or less given time, you are anticipating death. Here is a young man who's gone on a joyride and who dies, and how difficult it will be for this family to make sense of that loss, isn't it? So there are certain factors that can cause this sort of an can precipitate to complicated grief. One is the circumstance of the death of the individual, untimely death, as you said, and younger age group, death of a child, sudden unexpected death. Even in case of oncology also, when there is death is due to neutropenia during chemotherapy, right? That's a unexpected way of dying, isn't it? When there is traumatic death, sometimes when the death can be stigmatized, like in AIDS or in suicide patients. And sometimes if you see in palliative care, terminal hemorrhage, carotid blowouts are, when you see the way the individual dies, can, if the family witnesses it, it can be extremely traumatic to the family, right? The way the when the carotid blowout happens, that can be very traumatic. So these circumstances of the death are a biggest contributor to complicated grief. So our role as palliative care physicians come in when you ensure that, you know, these issues are, of course, sudden unexpected death, we cannot do anything, but the other circumstances of the death we can take care of. Then of course there is the personal vulnerability, as somebody said, the personality of the individual, the history of psychiatric disorder, the coping style of that individual, and if there is a repetitive loss that is occurring in a family, that individual might find it difficult to cope. Nature of the relationship with the deceased. Okay, when the family member is overtly dependent on the person who's dead in terms of financial security or in terms of all the other things, right? Or when there is an ambivalent relationship, when there is an ambivalent relationship, like, you know, slightly warm water. When the relationship is very ambivalent, then also that there could be what is complicated grief. And of course, family and support network, all of you have said, lack of good family support or social support is one of the reasons for complicated grief. So we need to keep all this in mind while dealing with individuals. And of course, there are some tools that are available for assessment of grief. There is this brief grief questionnaire, which is just about 5 questions that are there. And scoring on this will give you an idea whether this person is at risk, has complicated grief or not. And it can be even administered at a primary care level. We should familiarize ourselves with all this when we are dealing with traumatic situations, especially post-pandemic, you know, when the grief among people are very high. We have to be very mindful of it. And there is what is called as DSM and ICD have included grief into their diagnostic manual. And there is a disorder called as prolonged grief disorder, which has been labeled. There are specific diagnostic criteria, and this prolonged grief inventory has 13 questions, which will look at presence of grief disorder. So these are the newer additions that are there. And how can you help these people who are grieving? Grief is like an open wound. We have learned about wound care, isn't it? What do we do during when we provide care to the wound? A physical wound. What do we do? What are the steps in wound care?
I have to clean the wound.
Excellent. We have to clean the wound. Then
I have to apply
Apply a balm.
pardon?
Apply a balm.
Apply, okay, if the wound is superficial, just applying whatever medications would do. If the wound is very deep, what would you do?
Do a dressing.
Dressing, yes, you bring the edges together and suture it, isn't it? Okay, so it's similar to that. Grief is also a wound. It's just a deep wound that is there, right? First is to clean the foreign material out. Okay, how do you clean the foreign material out? You allow the person to express whatever is there, that anger, that guilt, the shame, the regret. Okay, whatever is there. These are the foreign materials that will prevent the healing. So give the person the opening to the grief. Allow them to talk about the death, what happened, how they feel about it. Generally, what do we say? Let's not talk about it. Everything will be all right, right? We don't allow the person to talk about how did the death occur, what happened, was there anything. So provide them that space to express their pain and distress. So the foreign material has to be cleaned out first. Only then will healing start. As long as guilt, resentment, blame, anger is there, healing will not happen. So allow them to express it. Then bring the edges of the wound together. How do you do it? You want that surface to be normal, isn't it? By bringing the edges together, you are giving that skin continuity, isn't it? You're normalizing that space. So like that, normalize it's okay to feel like this. Most people who have lost somebody like this do go through these feelings. Okay, it's okay to feel the way you are, right? Any unfinished business is there, bring closure to it. One of the things when one of my patients, caregivers came, I asked them to write a letter to the dead person explaining their pain. So once that letter was written, the person experienced a lot of those unfinished things was there, achieved closure. Okay, and in the process sometimes they find meaning why things have happened, and then provide the nutrients, as you said, balm or nutrients for healing. What are the nutrients for healing that you will provide here? Help the individual connect back to their day-to-day life. Okay, like ask them to get back to the routine activities that they do, help them connect back to God, help, provide that spiritual distresses, that provide that spiritual care, use, ask them to get back to their hobbies, right? So little by little, you start reconnecting them back. But remember, first clean out the foreign material, bring the edges of the wound together, and then only provide the nutrients, right? So if you keep these 3 steps in mind, talking to a person who's going through grief becomes much easier. Remember that there are certain statements that you should be saying, and there are certain statements you should not be saying. I know how you feel. It's very difficult for us to know, isn't it? I can only imagine what you're going through, but you will never be able to know exactly what the other individual feels, right? So be careful when you say, I know how you feel, or when you say, I can understand. Okay, they'll turn back and say, no, you can't understand what I'm feeling, right? It's always better to use the word imagine. And be brave. You be strong, be brave, something that you should never say. It's okay to not be okay. It's okay to cry. It's okay to feel that it's the end of the world. Okay, this will soon end. Don't worry. Everything heals with time. Remember, grief never heals. Grief will always give some pain or the other, but people learn to live with that pain. Okay, life is for living, or sometimes you end up comparing them. See, that person is doing, don't compare. Don't say you will be fine. I'm sorry. Let me know if there is anything I can do to help. Right? Instead of that, offer to do something to help that person. Okay, here when you say, let me know if there is anything I can do to help, you are again putting the burden of asking for help on the person who is grieving, who may not have that cognitive capacity to ask you for help. Instead of it, it is better to do things. If you remember, I mean, even now, when a death occurs, you don't cook in the house that day, isn't it? Till the cremation is over. Immediately after that, when my mother-in-law passed away, it was our neighbor who cooked and who sent food over, not waiting for us to cook also, right? Without asking us and telling. So like that, you have to do things for the other individual without waiting for them to ask you for help. So these are certain things that we need to keep in mind. And the red flags is, of course, when patients or caregivers express suicidal thought and behaviors, or when there is complete denial. Okay, the person is acting as though the death has never happened. When there is increased substance use, social withdrawal, when the feelings are interfering so intense that they are interfering with sleep, with eating, there is neglect of personal hygiene. These are red flags to seek help from a mental health professional. To conclude, grief is universal. Experience and expression of grief is profoundly individual. It varies from person to person. It is dynamic. It's not that today they are accepting, tomorrow they will be all right. It keeps fluctuating between the stages, and there are both positive as well as negative aspects to grief. Okay, it is transformational, and only 10% may experience complicated grief, but almost all of them require the correct support and help. That's something that we need to keep in mind, and each one of us as medical professionals, we will face death in whichever stream you are in. You will find dying patients, you will find sick patients. It's very important to understand about the grief so that we are able to communicate with them appropriately and prevent further complications. Thank you.
Thank you so much, Seema. We'll take up a few questions if there are any, like quick questions. You can either unmute and ask her, or we can type in the chat.
Ma'am Aditi, sure. So you have handled a number of families who are grieving. So you're an expert. So what my question is, how do you differentiate an expert from a non-expert in the way they manage grief? I'm just trying to explore what are the key things that you would do differently from a non-expert in handling a family which is grieving.
Okay. By no means am I an expert in grief, because I think, as I told you, every patient or a caregiver is different, and with each individual, you have to find your own way through. It's not that you have a definite, unlike, the SOPs or the guidelines for symptom management that you have. Unfortunately, the experience of grief is so individualistic. There are no set standards. But the one thing that I found very effective is having good communication skills and the ability to be silent during that, and give them that space to vent out the grief. You don't have to talk. It is just if you actively listen to what they are and give them that space to express their emotions. And as I told you, 80% of them are able to deal with it on their own. Okay, so just being a good listener, giving the space for expression of grief is enough. When I used to work in the subspecialty ICU palliative care, right? So how do you generally, are there any ICU physicians here or who work in critical care? Okay, if nobody is there, suppose there is a death occurs during treatment, how do you convey it normally? You must have seen during your MBBS days, right? How is it normally conveyed? Operative death or whatever it is, how is it normally conveyed? Anyone?
I understand there are surgeons and anesthetists in this group. Hope someone will, yeah, there is a chat.
Okay. So on the table, a death has occurred, right? How is it normally conveyed? How do you normally convey it? The exact setting. Is it done as outside the operation theater? You stand and tell the family.
I think you find a private place,
Hmm.
a quiet place where you can have the entire attention of the patient and the family. Start by saying that you have bad news.
Do you stand? Do you sit?
So we sit so that we're level with the patient. I think that is the setting, although we don't do that often.
No,
So,
I'm asking
yeah.
how is it actually done, not how it should be done.
Okay. In my setup, we're all standing actually.
Standing, no?
Yeah, we're all standing.
Yeah. So I think when you said, right, how would you do it differently? One of the things that I make it a point to do, I mean, I think the critical care physicians also, or the doctors have learned, is now to shift to a room, right? Whatever small room it is, and ensure if there are limited number of chairs that the family is seated when we tell the truth, because it's a big blow to them, isn't it? Right? And to be available to offer that support. Keep your time, give yourself that 20 minutes of time to deal with that wave of grief that is going to hit the family when you're going to convey the news. Not just tell the news and within 5 minutes run away from there for the next thing. It makes a lot of difference for the family if you are there to listen to their emotions or the outpourings or the questions that they are going to ask you at that point in time. Because that will give them the closure, that anger that they are expressing or the questions they're asking. How did it happen? Step by step, they will want to know what happened, and giving that truthful answer at that point in time to all the questions and being available there when they cry. The most important communication that you care comes when you are sitting there when they are emoting. I think that's one thing that maybe I do. It's not very complicated what I do, because if they need complicated grief therapy, I refer to a psychologist. I don't handle it myself. But this is where that is this family focused grief therapy and all that happens, which is done by a psychologist. But what I would do differently is give that time and that listening to the patient at that point in time.
Thank you.
Very simple, not very complex. And that empathetic communication, when you do it, they really understand that, they sort of, it is very therapeutic also for you and for the patient both.
So my question was from the point of view as to whether this is a skill that can be learned or trained, or it is a skill that is innate. So that is where, yeah,
it is trained. Actually, what they say is compassionate. I think empathy, when I speak, I'll speak about that. That is something that is trainable. That is an innate skill, definitely. But when we talk about empathy in the healthcare sector, that can be taught. It's a taught skill. It's about communication. It's about, learning the right way to talk.
Okay.
So it's a trainable skill. And most of us have it, remember. It is just that our time, our work schedule, all that, provides a barrier for us in expressing those skills that we already have. Most of us who take medicine are innately empathetic. If you look at personalities and choice of profession, many of us choose because we have that skill within us. It's just that it gets masked. I think the next session you will know why it happens. There is a very interesting study on this.
Thank you, Seema. So if you have any more questions, please let us know. Seema is always there we can forward it to her if you want more discussions. Seema, we'll take 2 minutes break for you, a water break.
Absolutely.
I understand it's very difficult to teach empathy. But yeah, I don't know how you put it in words, but yeah, I have given that responsibility to Seema. And you all are going to teach this session to the MBBS students, definitely for the first year and second year students. So please feel free to give your comments and anything after the session. Over to you, Seema.
Yes. So is the flight disturbing? Is the sound too much?
No, no, not at all.
Doesn't come, right? Okay, so it's only for me that it disturbs. Okay, so just give me a minute. while I- So what I'll be talking about is empathy. Why is it important, and how to develop a culture of empathy? Yeah, so you can see it isn't. It is visible in a screen.
Yes, it is.
Yeah, so I'll start off with a short video about empathy. Um, try playing it. I hope it comes through. Can you see it?
Yes, yes.
again, what did, any comments or any responses after seeing that video? I think you're muted, Dr. Srinivas.
Yeah, madam, everyone is having their own issues.
Yeah.
Out of these, many of them are bad ones, very few are good ones.
Yeah. So when they come to the hospital, many come with sort of, issues and feelings, and isn't it? Yeah. The thing is, how many of us as doctors or nurses or in our profession, we focus on that aspect of the individual. And what stops us from, being in the other person's shoes? Anybody?
Maybe we are too busy with our own work.
Busy with the work. Okay.
We also have our own issues.
We also have our own issues, our own, yes. Yeah, right. So, so let us look at again terminologies and understanding what each of it is before we go on into understanding what empathy is. So I've written some empathy, sympathy, compassion, kindness, pity. We hear a lot of terminologies, So are they same or are they different? Not able to see everyone clearly. Yeah. Sorry. So are they same or are they different? You can put in the chat or unmute yourself and try to answer. Yeah. Anyone? What is sympathy?
Dr. Lavanya is telling it's different.
Any idea how it is different? Okay, I'll make it simpler for you. There are two things you look at, okay? It's clear, right? This slide is clear, no? Yeah, okay. So one is about how much emotionally you're engaged with the person, your level of emotional engagement, okay? And how aware of you are with the other person's difficulties, okay? The least engagement, emotional connectedness that you feel to a situation and least awareness of the difficulty, you experience pity. Oh, it shouldn't have happened to that person, but that's it. There is no emotional engagement at all in pity. It is just that you feel you are on a superior and you're looking down on the person and telling, okay? And sympathy is a little more engagement is there, right? And you are able to understand a little bit better what the other person is going through, but you're not exactly putting yourself in the other person's shoes. That's sympathy. Empathy involves being, knowing exactly what the other person is going through. It's like, you're literally in the other person's shoes. You are able to feel what the other person is feeling and you're able to understand what the other person is going through. Exactly. So that is empathy, and compassion will come to it later when we discuss. So it's about connectedness with the other person and the understanding and awareness of their difficulty. So that is what it's again interconnected, and it is in a scale. Pity, sympathy, empathy, and compassion are along the spectrum, but the level of connectedness is different in each. Let's look at Mr. Agam, who works in a multinational company. He stays alone in Bangalore. He's a project manager and he heads a team. He is admitted to the hospital with stroke and he is unable to speak. His family is unable to travel because of the travel restrictions during the time of COVID. So how do Agam's colleagues react to his illness? Okay, and you will have to tell me whether they felt pity for him, they are sympathetic, empathetic, or they were compassionate. Okay, so Mr. Vishal, his boss, says, Oh no, he's unable to speak, poor man. It just sounds very awful, the situation he's in. What do you think this is?
This is just a pity, madam.
This is pity, right? Yeah, it is pity. Okay. Whereas Mrs. Vishal sends some flowers to him. What would you say this is? Okay, we'll leave that aside. Okay, Mr. Anil, his colleague says, I'm so sorry this happened to him. I feel really bad for him. What would you say that is?
Pity,
Sympathy.
again pity.
Giving sympathy. It is.
Pity.
You would call this also pity?
Yes.
Okay. Oh, okay, we'll check this later. Okay, Miss Asha says, I can imagine how frustrating this can be, not being able to speak.
Maybe sympathy, madam.
Sympathy.
Okay. Mr. Rohan gets a sign language book for Mr. Agam and teaches him the basics.
Compassion.
That is
Compassion.
compassion, isn't it? Okay, so let's see whether we are right. This is right, it is pity. Why is it pity? Poor man, it sounds awful, right? It's from, there is no emotional attachment to this, there is no understanding of the situation, isn't it? It is just, you feel from a position of having everything, you just say, poor man, okay? Then Mrs. Vishal, who's not connected to this individual at all, but Mr. Vishal's wife sent some flowers. It's a behavior, right? It's a behavior. It is an act of kindness. She's being kind by sending the flowers and a get well card or whatever it is, isn't it? But no emotional engagement, exhibition of a behavior. Whereas Mr. Anil says, I'm sorry I feel sorry this happened to him. I feel bad that this has happened to him. Here he is expressing sympathy, isn't it? It's not pity. He's not saying awful, poor man. He's saying, I feel bad. He's emotionally connected little bit to this individual. He's understanding the situation and he's saying, I'm sorry that this has happened to him. Whereas Asha is telling, I can imagine how frustrating this can be, right? She's named the emotion here, frustrating this can be, not being able to speak, right? She's experiencing it, she's experienced the frustration or the feeling that Agam is experiencing. So this is more of empathy. And as you rightly said, the last one is compassion. Empathy plus action is compassion. So you not only understand and feel exactly what the other person is feeling, but you're taking an action to relieve the suffering of that other person, right? So this is a fine line between, pity, sympathy, empathy, and compassion. And as doctors, what is it that we need? Which of these emotions is very important that we have?
Empathy,
Compassion.
Empathy and compassion. Yes, absolutely. Right? So it is an ancient trait. We have read, right, in the ancient past also, people were very empathetic, and it's a trait. It's an inborn for some, but it can also be taught. It's about recognizing other people's emotions through intuitive feeling what we say. When you look at the non-verbals, you look at the verbal, you look how the person reacts, and you are able to understand. Did you notice in that video the facial expressions? Okay, you saw an elevator. There were two people, one whose tumor was benign and the other whose tumor was malignant. What was the guy whose tumor was malignant doing? Did anyone notice? Do you recall that clip? You can see he's biting his lip and trying to control his tears, and he was drumming his fingers on the elevator. Sign of anxiety, isn't it? The one whose tumor was benign was relatively relaxed. right? The facial expressions. Okay, so when we talk about intuitiveness, it is about being heeding to, yeah, moving fingers, and yes, Lavanya says moving fingers, yeah, drumming the fingers on the elevator. So it's about being very cued to the non-verbal, the posture, the expression on the face, the tone of the voice, etc. And it has both emotional as well as empathy, has both aspects to it. And there are two things that we call very important to be empathetic. One is curiosity. First is we need to have that need to know what the other person is feeling, isn't it? Until and unless we are, if we are not curious, we will not be able to imagine what the other person is going through. And the second aspect that is needed is what is called as perspective taking. That is an ability that you have to put yourself in the other person's situation, to acknowledge their point of view, and to understand their behavior, their emotions through that, by, with their eyes, to interpret their behavior by understanding what they are going through. One of the things that I do when I am with the patient is, how would I feel if my parent was there? How would I feel if my spouse was in that place? What would I expect from the doctor, right? And to do the same to the patient, that's an easy way to relate, and to learn to be empathetic. What would I want? So perspective taking is a very important aspect of being empathetic, right? And there are three types of empathy that, as we see, one is what we call as affective empathy. It is an ability to feel the other person's emotion. Means many times when we have seen a very distressing emotion on the movie or something, we have cried along with that, isn't it? Right? Why did we do that? Because we experienced that affective empathy. We sit crying. Sometimes our patients will touch us so much that we end up crying when we listen to their stories, isn't it? That is affective empathy. Cognitive empathy is more of an analytic point of view. You are understanding what the other person is going through. Intellectually, you are able to understand, but maybe your heart isn't as much affected as in affective empathy. And compassionate is cognitive empathy plus your ability to take action when you understand and you feel the pain of the other person. That is called as compassionate empathy. Among the three empathies, which do you think a doctor should have, and which a doctor should probably be very cautious about experiencing? Anyone?
Ma'am, compassionate empathy.
Should have or should not have?
Should have.
Okay, compassionate you should have. Okay, which should you not be very wary, not have Allah, which you should be wary of experiencing, little careful about?
Effective.
Who said that?
Nandakishore.
Okay, absolutely. Why affective empathy can be a bit harmful?
We could, start either two ways. One is you end up compounding the patient's grief, or it could be harmful to our own personalities.
Absolutely. Have you heard the word compassion fatigue?
Yes.
You have heard, right? So in individuals who experience more of affective empathy, right, that who feel exactly what the patient is feeling, okay, you will run out of compassion very fast, isn't it? You will get tired, you will burn out, you will experience compassion fatigue. Whereas cognitive and compassionate aspects of empathy will help you to be very productive, keep going on without getting affected. So I'm sure when we were students, I've heard sirs tell us, don't get very attached to patients, right? Be very objective. Okay, they will tell, isn't it? I mean, I have heard my teachers tell me that, don't get very involved with patients, don't be very objective. Actually, what they mean is empathetic, you need to have cognitive and compassionate empathy. Affective empathy, you have to be careful about. See, when we walk in water, your feet is bound to get wet. So there are times when somebody will affect you emotionally. Okay, it's bound to happen, but it is important that when that happens, we identify it and we seek help at that point in time. So I hope so much is clear about empathy before we move on to the next section. So when we talk about empathy in healthcare, as I said, there is the brain part of it, which is cognitive empathy, and there is the heart part of it, which is affective empathy. One of the first thing, empathy in healthcare, what we define is we need to have cognitive empathy, that is ability to understand our patients and what they are going through, the difficulty that they are going through. That is cognitive empathy. The second aspect is, as you can see in this Calvin and Hobbes comic. Some of these Calvin and Hobbes are very interesting comics with a subtle message in them. Okay, when a person pauses in mid-sentence to choose a word, that's the best time to jump in and change the subject. Okay, it's like an interception in football. You grab the other guy's idea and run the opposite way with it. Okay, what does that indicate to you? Does it tell you something about communication? Anyone? Okay, so studies have said that doctors tend to interrupt the patients a lot. Okay, so how long does a doctor spend when you see a patient for the first time without interrupting the patient? Any idea? 1 minute, 2 minutes, few seconds, any idea?
A few seconds. Maybe.
How long? How long is the few seconds? You're absolutely right. 18 seconds is the time that when we ask them, why have you come, right? Doctors will interrupt in, majority of them will interrupt in 18 seconds. Okay, but the studies show that if you give them about a minute or so, all the concerns, 8 seconds, okay, that's a little short. Yeah. So the second aspect of empathy in healthcare comes in being able to convey empathy through communication. Okay. So it's extremely important that we train ourselves in empathetic communication. And the third aspect is about compassionate empathy, that is doing everything that we can to relieve the suffering, which most of us do anyways, whether we are in whatever field we are in, what we do is reduce the suffering of the patient. The two aspects is being able to understand what they are going through and being able to communicate. So when we talk about empathy in healthcare, these are the three things that we should be looking at. The definition is this. Okay, so we have to understand that empathy is hardwired. Okay, there is a neurocognitive process that is happening when we experience empathy. One of the theories is the presence of what we call as a mirror neuron. Okay, so experiencing pain triggers these particular areas in the insula and the anterior cingulate cortex. But when you watch someone experiencing the pain, but you don't experience the pain, but you're watching another person who is going through a pain, the same areas get stimulated, but to a much less extent, right? So which indicates that empathy, you don't actually have to feel pain to what is that, to be physically experience pain to cognitively experience the pain. Just watching somebody in pain triggers the same areas, indicating that there is this communication. The action happens, you observe, and your brain imitates the action and senses it. So this is called as a mirror neuron. This is an unconscious mimicry that happens, and there is an effective aspect in the prefrontal cortex, ventromedial prefrontal cortex, and the orbitofrontal cortex for the affective, and the instinctive empathy that comes in suddenly as a trait naturally comes from the primitive area of the brain, that is the amygdala and the insula. So this instinctive empathy is something probably which is affective empathy that we are talking about, right? So these two together contribute to that. So one, it is hardwired. Two, there is something called as the theory of the mind. Okay, it is what it says that this tells that it is an ability to understand somebody else's thought process. Every individual, it has this particular ability to understand what the other person is. We think that we have the ability to understand. We sometimes are able to predict and interpret others' behavior, right? A simple example is what we called as the test of deception. This is one story. This is there. This is Sally. This is Anne. Sally has a ball. She puts it into her basket and she goes for a walk. Right? And takes the ball from the basket and puts it into the box. Okay. Now Sally comes back. She wants to play with the ball. She has not seen Anne put the ball in the box. Right? Where will Sally look for the ball? In the basket or in the box? Yes,
Basket.
Lavanya. Lavanya has raised her hand.
Basket.
Basket. Okay, Srinivas.
Basket.
Basket, right? Okay. If you ask this question to a 3-year-old, what do you think that child will tell you? What do you think that child? Okay, Lavanya, your hand is still up. Any idea what a 3-year-old will tell you? Any guesses?
Because I have kept it there.
Yeah. So box. Somebody has written. Who has written box? Arun. Any pediatrician here by any chance?
Maybe she will look for both box and basket.
Yeah. The child will tell you it is in the box. Why? Because the child knows it is in the box. He cannot predict the mind of the other person, Sally. He has not, his cognitive process are not developed, right? To predict somebody else's behavior. Did you understand? So he knows that it is in the box. He thinks the other person will also know. Right? But we as adults, we understand that an action, there might be different, right? The reality, what we think and what is there can be different. We have learned to differentiate that, right? So this is called as the theory, your ability to understand and predict the action of the other person based on the facts that is available to you. That ability comes only in an adult mind as you grow older. And that is called as the theory of the mind, right? And this is that theory that helps you to empathize with the other person, because you will be able to predict what the other person is going through and able to understand that, right? Is that clear? So what I wanted to tell you is that there is a biological basis to the empathy, there is a behavioral basis to the empathy, and there is an emotional basis to the empathy also. So what we have to do is that pay more attention to these processes that is happening, and definitely benefits of empathy in healthcare is quite a bit. There is better patient and caregiver satisfaction that happens. Workplace becomes less stressful if you are working in a very empathetic environment, and it also has better health outcomes for the patient. They are more adherent to medications if the doctor is very empathetic, reduced pain, reduced mortality, complications are lesser, and lesser medico-legal cases also, when the doctor is empathetic and communicates empathetically. Okay. And there is also a study that to show, I think this is what I told you last time, that empathy declines during medical training. The first 2 years of medical training, the individuals are very empathetic. But from the 3rd year, it is called as the devil in the 3rd year. From the 3rd year onwards, the empathy starts going down in medical doctors. And they call that this clinical transformation as the battered child syndrome, and is attributed to inappropriate treatment of the medical students. And during post-graduation, it reduces even further. That is the study. When they do specialization, as you specialize, they say the level of empathy comes down. And this is because there are a lot of reasons that has been given, especially the work environment is one of the main reason why there is this decline in the empathy, right? So modern medicine, more of, we are looked at as dispensers of test and treatment. Okay. And we have standard operating procedures. We have evidence-based guidelines that will tell us what to do. Okay. And patients are passive recipients, right? We dehumanize them. We don't even remember their names. But if they say it is a case of CA cervix, CA lung, right? That's how we remember our patients with the complications that they have. They're completely dehumanized, and doctors are also dehumanized, isn't it? I don't think sometimes as residents, when you're working, if I ask my patients, which doctor did you see in the oncology? They will tell, we don't know the name. Every time there is a different doctor there. So we don't know the name. They don't even look at the name tags. They don't know the name of the doctor, right? A lady doctor was there, or a gent doctor who was wearing a specs was there, or an elderly doctor. They will tell like that without knowing the name. So doctors are dehumanized, patients are dehumanized, and the system, the medical system itself has devalued the doctor as well as the patient. Both are devalued. It's not one or the other, both. So this is the reason why modern medicine and empathy today are, at loggerheads. So how can we nurture empathy? We need to create an organizational culture. And one of the important things is valuing the personhood of that individual. Okay. So there was this study which was done and published in a journal, which talked about my life, my story. So along with the case sheet, a 100-worded story about the patient was given to the doctors. Okay. So the doctors knew not only about the history taking, chief complaints, presenting complaint, but about the individual, what they were, what were their dreams, their aspirations, and the short 100-worded biography. And when they were added to the medical records, it showed that there was better relationship and understanding between the doctor patients. And when they looked at patient satisfaction, doctor satisfaction at the end of it, it had improved. So one of the takeaway points from this is we need to, as I said, understand the patient as an individual, right? And that helps a lot in helping us make more empathetic. When we understand the background that they are coming from, the difficulties that they are having, other than the medical difficulties, it helps us to be more empathetic towards the patient. And how do we express our empathy, right? One is developing that empathy within ourselves by understanding their perspective. Second, how do we express empathy? You've had a communication training, right? Was there any training on how to express empathy? One is about whatever we do, we have to ensure that the care that we provide has to be dignity conserving, addressing patient by the name rather than, by the file number or whatever, or the name of the disease. That's one of the things that we need to change. An attitude which is non-judgmental, of genuine concern and respectful to the patient. Behaviors like while getting down from the examination table, just helping the patient when they are getting down, or making the patient, showing those, pulling the screen in the bedside examination, may pulling the screen to protect the privacy of the patient. These are all examples where you can enhance the dignity of the patient, providing compassionate care and communicating with empathetically. So there's a protocol called the nurse protocol. Ability to, talk to the patient in an empathetic manner, listening, using a lot of non-verbal like touch, allowing patients to express their feelings. These are all various mechanisms that you can use to express empathy. And in conclusion, I want all of you to tell me, what do you think is the empathetic care that you can take forward with you? I'll stop sharing and we can start discussing. So the conclusion I'm leaving to you. So you know now what is empathy in healthcare, where all are empathy impacted. Now, how can you improve? From your point of view, how do you think you can improve empathetic care in the circumstances that you are in?
You're muted.
Yes,
Seema.
sorry, active listening. Okay, fine. And what do we mean by active listening?
Paying attention to what the patient is saying. You can paraphrase whatever they are saying, confirm, is this what you're saying? Do I understand you right? Things like that.
Excellent. Yes. Sometimes it could be verbal through paraphrasing and, rephrasing what they say. Sometimes it could be non-verbal, that through gestures and through, your expressions, silence, touch, etc. Absolutely. Thank you. Empathy is something we understand the patient needs and help them in 360-degree medically, etc. Okay, fine. Okay, and so one thing is it's innate for some, but it can be learned. It's just that we need to be more mindful of how we can incorporate this into our day-to-day practice. And especially when we teach medical students, I think it's extremely important to tell, that it has to be part of your day-to-day care. Being empathetic should be part of the day-to-day care. Yeah, that's it. Thank you.
Thank you, Seema. I'm sorry, I'm rushing to the small groups now. We have 20 minutes of small group. So we are kind of covered all the topics that has been mentioned in the second year medical education, the revised curriculum. So next 20 minutes we'll spend in small groups. We have divided based on the institutions. I think only JIPMAR group will join another group because you have only 2 members. So just come up with some ideas that how are we going to implement this? We have few more years to cover, but at least from this point onwards, how can we start? You might have already started doing, but how can we go ahead with this? How can we start implementing this particular program of integrating palliative care? One person in the group, if possible, please make a note, type it in a Word document or one single slide so that it's easier for you to come back and present it to the larger group. I hope I am clear. If there is any doubt, just let me know. So small groups, we come up with an implementation plan based on each institute because each institute has its own culture and its own dynamics. So just come up with a few points. How can we go ahead with this program? One slide, if one member can just type what we are discussing in the group and come back to the large group after 20 minutes and share among the large group. So dividing you into the small groups, we will have mentors in every group. So see you after 20 minutes.
that we will be having theory session. We'll be having so many theory sessions also, because the idea that I had was maybe communication part, 8Com was the one that we were targeting. But no, it is not 8Com alone. It is the whole curriculum from first year to the final year. So, the key point is identifying what is happening presently, identifying the key persons, and introducing this, and without burden. I admit that at present, to start with, it won't be perfect. It won't be as smooth as we think. It won't be as perfect as we have put it in these modules. But something is always better than nothing. And this is definitely a start. And this will definitely work. But one thing that I would like to ask is, how many more modules are left? Because it is important to have the full picture before we start off. And in our group, what we felt was palliative care has to be taught in the ground, or means in the bedside, in the wards, than through lectures, because it can be a little boring and it can take off. I mean, the concentration may not be there. It will be just another lecture. And another important point that Dr. Arun made was the degree-centered learning, or the degree-centered curriculum that presently exists. From degree-centered curriculum, so it emphasizes on exams and passing exams. So if these topics don't have an importance in exams, the chances of students skipping them is very high. And also the second year is cut short to 1 year now. So when we are introducing these topics with pharmacology, and what I have, I am in internal medicine, so I don't have a direct involvement with CBMA right now. Only some students have come and gone for postings. But what I have found with first and second year teachers are that they are stressed. They are overworked because of the confusions with CBMA versus the conventional teaching. And during this confusion, actually, that's what I said, it can act as an advantage as well as a disadvantage. The clarity of what we put forward is important when we approach these departments. And we have also earmarked the number of hours that will be given. I don't know whether so much of time is actually available, because the CBME curriculum definitely tells us so many hours for each topic, but there is a conventional method of teaching topics. So teachers have not yet come out of that conventional method also. So CBME might put emphasis on many topics, but the question paper setting, it will also take time to change, and it has not changed much over the last 2 years. So what we will have to identify is to put it more practical, like what Dr. Rakesh mentioned. In pharmacology, yesterday we were also mentioning, we have an area for prescription writing, good prescription versus bad prescription, and maybe we can include this at that area. So at the institutional level, we will need to rework on these modules and have a document of our own. So so that how we will be implementing it across the phases. We will need stakeholders from every department, the departments that we are identifying, and go forward. And exams should have questions from this, and students should not feel that a new thing is being taught to them. They should feel that it is part of the curriculum. Only the faculty should know that this is being implemented. For the students, it is business as usual. They are going through the 4.5 years of study, and they are learning what is required in the way that it should be taught. That's it, ma'am. Thank you.
Thank you so much, Dr. Anish. When you are telling about the CBME and its challenges, I was thinking exactly in the same way. It has a disadvantage and advantage, that it's easier to introduce something new because anyway everyone is confused about the new thing. But I think I would like to hear from maybe Dr. Dinesh about the concerns that Dr. Anish was telling, like the transformation from the conventional education and the CBME, and we are introducing, we are not introducing something new, but we are, maybe a new style of teaching. Dr. Dinesh, would you like to just give some comments on that?
Yeah, while agreeing with what Dr. Anish has pointed out, which we discussed in the small group also, thing is, this question is very likely to come. Why so many new things and all these things? So one thing which we need to very actively try is mapping of the main objectives or the competencies of the modules which we are suggesting to the existing CBME curriculum. So the document which we have partially worked in on that. So it is, we have to show them the connection that whatever we are suggesting is only a repackaging of some of the competencies which are there. So we have to kind of try to convince our colleagues in other departments that there is nothing new which is coming. So this is the list of all the competencies which is expected to be taught or delivered as part of CBME. And these are the set of competencies which are repackaged as these modules. So these modules, while we are delivering, it is likely to be like they will see that there are certain hours being dedicated, but we need to make it very clear that these hours or this time which is coming is actually we are covering these competencies which need not be again covered in the delivery of the CBME curriculum for those subjects. So this is one critical thing which we should try to emphasize in all our discussions with the authorities. Also, when we are talking to the students also, so as again Dr. Anish pointed out rightly, they would be more focusing, like they might feel overburdened. We are overburdening them with one more extra module or something. Okay, there also we need to again convince, bring it to their notice that this nothing extra is coming out. It is only the things which have been teased out from the entire 4.5 years and which are being offered in a slightly different package. So which they could use it to enhance the, say, overall flavor of the MBBS package which they are planning to deliver. So that would be my suggestion at this stage.
May I say something?
Yes, Dr. Reena, please.
Actually, I was hearing from Amla. So one big advantage that you have is that you're in a mainstream department of medicine. And I fully agree with you that, without examinations, not all students take it seriously. So what I was wondering is that in your internal assessment or end of posting, is it possible to, include an OSCE on breaking bad news? Is it possible to include a short note on pain management? And what you said about the prescription writing is an excellent place to bring in the pain ladder, because that will carry a lot of credibility. So besides the stakeholders who are mapping the competencies, the people who are setting the internal exams in your own departments, what can you sneak in, was a question that came to mind.
Surely, ma'am, that can definitely be done, because that's what I said. There is already a confusion on CBME. So we can actually use it to our advantage at this point and make sure that, yes, in internal medicine, maybe one question should be from this area and it should be compulsory. And that can be made aware, the students can be made aware that this is there. So definitely this portion carries a weightage for the exam. And it can be done in internals, definitely, yes.
And a communication skill OSCE, because that again is a must know in the competency curriculum. Things like that. Thank you, sir.
Thank you, Group 1. We'll build up more ideas on that. So we'll go with Group 2, group from Geetam. Dr. Srinivas, you're muted. We can't hear you.
Yeah, this is Dr. Srinivas from Geetam, Madam, Vizag. So based on our short small group discussion, we have concluded some points. As Anish sir and Dinesh sir already mentioned some challenges for implementing this program. So based on our small discussion, so first point we have to do is we have to interact with our management, how to implement this program, and regarding which phase we have to teach all these topics means we made a statement that to be included in phase 1 and phase 2, that is first year and second year after joining And what are the various techniques we can use for implementation of this program is we can use role plays, we can use lectures, and we can use case scenario discussions. And if possible, we can take real case discussions in our wards and in our ICU setups if available. So based on the availability. And next one is for this implementation, we require time slots. So for that, we have to take coordination from other first aid departments like physiology, anatomy. And next one is, as Anisa told that if they are not included in their regular exams, whether they are internals or externals, so student will ultimately skip all these sessions, all these topics. So we have to, at least we have to make them aware that all these may come in their exams so that we can motivate them to know about all these topics. So that's what we have discussed and concluded, madam. Thank you.
Thank you, Dr. Srinivas. I think we'll just quickly move to group 3 so that we can hear from experts. In the end, we'll have some time from them. Group 3, I think, was from MGMCRA.
Ma'am, can we take it up after 5 minutes, madam?
Yes, sir. Sure, sir. So then we'll go to PS Institute. I think Dr. Chitra and team. There were 2 groups in with you, right? Dr. Chitra's group and the JIPMER. So we can start with Dr. Chitra, please.
So this is Dr. Anil here.
Yes, sir. Please go ahead.
This is Dr. Anil here from PS Institute from Department of Community Medicine. So the first I would like to highlight a few challenges what we discussed in the group for implementing this program. First one is, see, when in a college where palliative medicine is not present, so there, the people who are handling this might require hands-on so that, it becomes more easier for, presenting it to the UG students. So hands-on training might actually help us. That is first thing. Second thing is, faculty agreeing to give time. That is the second point, second challenge. Probably that can be addressed by, arranging for a meeting where the curriculum implementation committee as well as all the HODs are there. And one, idea what we found out is one resource person for each year, like that can be from anatomy, physio or biochemistry, where one person. So that person for each year, one person, and those 4 people should be trained or not trained, or at least orientation on what is happening, how to integrate this, modules with the AdCom. That has to be, oriented for them. So that will become easier for us to coordinate across the 4 years that what has happened. So, and what we thought about the time is AdCom modules actually can be modules from each subject. So there are around 140 hours of total AdCom hours. So in that, hardly we require say around 20-25 hours to implement this. So probably we can, make the HODs agree upon this and utilize that AdCom time for, giving this. And there was a concept of elective postings, which maybe from this first year onwards, family adoption can be there. So using that elective postings or family adoption, a few students can be allotted the families where, you have these patients with long-term illness. So probably that can be helpful for us, to present the cases in the large group. And questions and assessment on the other subjects. Yes, it is very important for them to include in each of those subjects. So probably that's what, as our mentor in the small group, she said that there are question banks which we can prepare, and we can give handmade, ready-made questions to these, people who are setting up the questionnaire. Either it can be the HOD or one person, resource person. So they can actually include one question in each of their internal exams. So that actually will help the students to, be more serious about this. And in the community medicine as such, we can have more of OSCE and OSCE, which can be helpful to, bring out this communication, as well as in the second year pharmacology, as madam said, prescription writing. So these are a few things where you actually, include, palliative medicine. So I don't think so that can be a burden for the students, because they are enjoying these AdCom modules. As we are doing AdCom modules for the third year MBBS students right now, they actually enjoy. We give them the assignments of doing these role plays and all, and they enjoy a lot. So, bringing palliative medicine, they will learn with enjoyment. And this is kind of pretty serious, like, empathy and what we learned about grief and all, it's kind of very important. So when we bring it out with case scenarios, I think it shouldn't be where we make the students feel it's a burden. So that's my point of view. Thank you.
Thank you, Dr. Anil. You have told about the challenges and how to overcome those challenges in a practical way. That's that is a good plan from your side. I'd like to hear from Dr. Adi and Dr. Nandakishore. Anyone from your institution?
Yeah, I'm Adi. We just discussed with our mentor, Dr. Aditi, and we were clubbed with MJ, I think PIMS people. We already have a palliative care clinic going on, and with once a week home care going on, and some IPD beds for palliative care patients as and when needed on an individual basis. And Dr. Nandakishore is one of the core faculties of medical education. He has joined this program in an attempt to see how he can streamline palliative medicine into undergraduate curriculum. Two things we are looking at present. Last time when Dr. M.R. Rajagopal came to our institution, he had a discussion with the Dean Academics, and they said this has to be tabled in front of the academic council, standing academic council or committee, for them to ratify the inclusion of palliative medicine in the curriculum. And then only fixed hours can be allotted to palliative medicine, plus 1 or 2 questions in the theory paper, maybe internal medicine or wherever they choose it to be. Until that happens, we are trying to see how much time we can get through, because Nandakishore feels there are already some aspects which are being taught to students as form of 8Com and other things. Can we extend it a little bit and include the palliative aspect to that? Like in pharmacology, when they teach opiates, can we train one of those faculties and to see whether the palliative concept of morphine and other side effects, other things can be taught to students there. And in medicine also, whenever we talk of pain management or anything else, or in surgery or in anesthesia, can we include those things? That is one aspect he will be trying to explore when he gets back after this FDP. Other thing is we will table the contents to the academic committee and see whether we can get a full-time proper schedule for palliative medicine.
Thank you.
Nandu wants to add anything, he can.
I think you said whatever we had in mind. Thank you, Dr. Adi. Yeah.
Thank you. Any of the faculty would like to comment at this point?
Yes.
Anyone, Dr. Reena, Dr. Rajgopal, or any of the mentors?
Sri, can you hear me?
I think I'll wait for the others to speak first, because
Okay,
I'm hearing so much wisdom from the comments that I've been listening to.
Okay.
Ma'am, can I take it? Ma'am, Dr. Kannan, can I take it, ma'am?
Sir, just a moment. Dr. Reena is about to tell something, and then we'll, just give me a second.
I think what I was just going to say is when you approach the academic committee, if you can suggest this much time I will give from my current schedule, they may be more open to it. And it's always possible for us, to put in a case scenario about this or that. So that was one thing. And what was the second thing that I noted? Yes, they're talking a lot about early clinical exposure and integrated learning. So you had mentioned asking one of the pharmacology people to take cancer pain management. What could be even better is if you could ask the pharmacology person to allow the palliative care doctor also to come for that session. So he provides the clinical angle to it, and it's a class done together, because students find it very exciting when a clinician comes in and it's a combined class.
Thank you, madam. We will keep that in mind as when we approach our academics committee. That's a good suggestion, ma'am.
Thank you, Dr. Rina. Dr. Dinesh?
Yeah, so just continuing with what Dr. Reena was mentioning. So it will matter how we'll present our case to the different councils which are governing different organizations. But also, like, we need to focus on the three-pronged approach. One will, of course, be the official thing, which Dr. Adinarayan mentioned, because each institute will have its own administrative pathways, and of course, we cannot shortchange those pathways. So we have to be aware of those and definitely go through those. Also, wherever we get a chance, like informally, whatever part of the curriculum we can deliver. So overall, it would lead to the overall sensitization of the institute and maybe more favorable atmosphere in the entire institute to accept those proposals. Third thing is, again, just to re-emphasize on what Dr. Reena told, the integration part which is coming out of the CBM is a very excellent opportunity. So where we identify the like-minded people and other and try to integrate some of these topics. So as she told, like when there are such sessions which have got significant importance for the palliative care modules, so those topics also, if certain of those topics, if you identify and be part of those discussions as maybe additional faculty or integrating on the co-integrating departments, that would be the third strategy which we can use. These three strategies which we might try. Thank you.
Thank you, Dr. Dinesh. We move on to next group, Dr. Kannan.
Yes, ma'am. This is Dr. Kannan, ma'am. I'm from Mahatma Gandhi Medical College. And ma'am, with our team, we had a discussion. So what had transpired was it's better to have first the methodology. How do we integrate? So methodology of integrating, I think as my mentor was telling, it can start at the year 1, year 2, year 3, year 4, and then finally to the internship. Instead of rushing it immediately through all the 4 years or 5 years continuously, do it step by step, take baby steps so that it becomes much easier. So we had actually prepared some sort of a plan was there with the amount of hours, with the which department has to handle what and which has to be the collaborative department, what will be their aims and objectives, what could be their outcomes and all that. But still there should be quite a few hurdles which my mentor was asking. So I was just thinking what could be my this thing. We have to take it forward with whatever group which we have done right now, which can be a core group and involving other broad specialities and the other clinical and paraclinical. I think there should be a support group, and every department should have one dedicated person who will be a one-point person for either for integration of the palliative care academic level or for the clinical thing. So which will go hand in hand together for improving the care as well as for improving the patient inputs and patient this thing also. So looking at it, as was rightly pointed out by the other members, it has to go through the curriculum committee, it has to go through the board of studies, and then it's and every department, we should people we should train them, and we should find out, we should map what is their curriculum, and map our own curriculum also, and then find the broad areas where we can integrate. And instead of we should identify like about certain hours, but it might be a little tough to bring in certain hours for all the departments. So like in general surgery, if I am talking about malignancy, then I should probably talk about palliative care also, like about in a malignancy or lymphedema care, etc. I think I should add it along with my regular class, add extra 2 or 3 slides onto it. If we can do this for all the departments, then it will be much easier. That is at one level. Then how do we assess them? It's going to be a little tough because it is not important for them for exams. So we have to have some sort of an incentive-based assessment has to be there. and we need to bring in some lot of role plays and a lot of other extracurricular activities where we can have slogan writing, we can have photography competitions, etc., which the student council can also do it up, and I'm sure they are very, very interested to do it. In our own experience, we have identified it. And the other important is to have some sort of an OSCE for the interns. The interns, when they come, I'm sure, starting from empathy, starting from communication, everything should be handled, and we can have standardized patients where we can talk to them at regular intervals, and before they leave, do some sort of an OSCE and then give some sort of an incentive. So this is what we see needs input. Thank you.
Thank you so much, sir, for the ideas on especially on how to implement at various levels, and then going through the curriculum committee and various assessment techniques. I wanted to point this out that we have mentioned a lot of assessment techniques in the trainer's guide itself. In the end, you can see different activities being just suggestions on how to evaluate each module. So if whenever you get some time, just go through that trainer's guide. In the end, they have mentioned various activities as well as the MCQs or questions or essay writing competitions is mentioned. We'll quickly go to the next group, Pondicherry Institute of Medical Sciences.
Good evening, everyone. I'm Dr. Kumar from Pondicherry Institute of Medical Science. Actually, we had a small group discussion with our mentor, Dr. Aditi, and few points we have come up with. Actually, as our college doesn't have any palliative medicine department as it's currently now, so we have to build up a palliative medicine department. And we have we are teaching undergraduate students through the new AdCom module. But these competencies which comes under palliative medicine are right now they're taught through humanitarians. That's a separate committee where these modules are being taught. So we will be talking to the Dean MEU and the AdCom Dean so that we will offer our contribution so that we can also help in teaching this palliative medicine to the undergraduate students. And before that, what are the challenges is first we have to find out what are the competencies which comes under this palliative medicine. So we have to identify these competencies and we have to see what are the competencies have been right now taught so that competencies along with this, whatever we can offer contributions along with already existing thing we can do. So for that we have to know the competencies which comes under palliative medicine. So if we can provide us what are the competencies which comes under palliative medicine, we can ask our Dean MEU. So these modules can be taught by us so that they can be better understood by the students. This is what we discussed.
Thank you, Dr. Shiv. I think now I'll give I would like to hear from the mentors here. Like there are many people who have at least started doing a little bit of integration here and there, or who were a part of this whole workshop. Dr. Aditi, would you like to add on something?
Shri, I just want to, can you hear me?
Very low voice, can't hear.
Very low. Okay. Now?
No, it's still very low.
I'll put it in chat, okay?
Yeah. Sir, because you have some other commitment, I think we'll hear from you first.
I have, ladies and gentlemen, so happy to hear all the progress and all the discussions. You were actually talking about solutions, and I do not have a lot of comments or advice or anything to give, but I do have a few questions. Shivakumar just now asked, what are the competencies that come under palliative care? And so somehow I remember that maybe Dinesh, or I don't remember whether it was Naveen Salins, who had prepared a table listing out all the competencies that are related to palliative care.
Yes, sir, we have that document.
That has not been shared with the group, perhaps?
Sir, actually, whatever been shared with the, like each document has its competencies mapped, but I'll forward a single document so that it's easier for you to relate.
And yeah, I mean, I think it's absolutely important. Right now, Aditi, by chat, is sending a message asking for that document. I'm sure that will be useful. Yes. So, Shivakumar, that will going to be done today itself.
Thank you, sir.
Something that was related to what Reena said a while back. Do I understand correctly that all universities or deemed universities, including deemed universities, have an official provision for appointing adjunct faculties? So, in relation to, can clinicians come in and join as a faculty for a session? Well, I'm not saying that it is necessarily a paid thing. Maybe an allowance will be paid, maybe not. Maybe it will be honorary. But if somebody is willing to come and assist in teaching, they can be appointed as an adjunct faculty, right? Who is knowledgeable about this?
Yes, sir, there are guidelines on that.
Is it a very complicated process or is fairly simple, Doc?
It is not, it depends on the management.
So
No. If
Sir,
the management wants to do it, is the process simple or complicated? Is what I mean. Of course, the management may not want to, and that's, I can understand that. That kind of thing may happen. Yes, Dr. Kannan?
Sir, I think we may have to impress upon the management the importance of having an adjunct faculty, because, sir, we are clinicians and we are just getting trained. But then having people who are trained in that particular department to be a mentor for our own department is always the most important thing. And from private medical colleges or from institutes, standalone institutes of national importance and all, things we can impress upon the top management level to do that, sir. That won't be a major issue, sir. Because if it is win-win for the administration, for the patient care, and for the teaching undergraduates, then people might understand and people.
Okay. Thank you, Dr. Kannan. Yes, I mean, like managements may not want to. What I'll drop that subject right now. The provision is there, but with a government system, the formalities can be a little too much if somebody wants to make it complicated. On the other hand, is the system such that the head of the institution, just with one order on one sheet of paper, can he or she just appoint that person? Is a question. Anyway, I see that it is possible. So we don't know the exact procedure, but that's okay. And I don't think that we don't have enough possible adjunct faculty to cater to the whole country, of course, 272 plus medical colleges, but whatever is possible, that will be very important. Thank you for mentioning that. Doctor, I heard Dr. Anish say that just virtual education is not the way medical education is to happen. You have to see it being practiced. Of course, at the same time, the reality is also that it is not possible. And such a tiny minority of institutions have palliative care programs, we cannot have clinical learning. So the classroom sessions or virtual sessions are sort of very inadequate compromises we are making. And I would think it is still better than nothing. But arising from that, I have this, I always nurtured this hope. I have nurtured this hope that just the awareness of the faculty about palliative care itself may be a catalytic force to start palliative care units. Is it an ideal dream, or do you think that is happening? Just conjecture. Did I make myself clear with my question? Even if that question is not answered right at the moment, I am just happy to leave that thought with you. Who just now said that you don't have a, Shivakumar said, you don't have a palliative care unit in your institution, right, Dr. Shivakumar?
Yes, sir. Yes, sir.
Dr. Shivakumar, with some learning in palliative care that's happening as a result of these discussions and as a result of the syllabus itself, the curriculum itself, do you think that is enough as a nucleus around which a new palliative care service will start? Or is
Yes,
that
sir.
too
We are,
idle a dream?
Uh,
no, no, sir.
I have one thing to say. When we were medical students, ENT and all were not separate subjects. Even actually, we never had pediatrics also. So as time grows, for everything a time will come. And cancer burden and other non-communicable diseases are going up so much. So palliative care has to come in. There's no other choice.
Okay, thank you. Reena, I don't know why I am talking to you, possibly because you are the first on my screen. Based on all this activity over the last few days, did you have a mental idea of how we are going to move forward, trying to reach out to as many of the institutions as possible? Do you have a roadmap ahead of you? I'm just asking you to start, and maybe we'll get precious input from the others also.
I'm thinking on my feet now. Were you talking about this group, sir, or beyond that?
Beyond that, Reena.
Beyond that, right. So if we're thinking beyond that, I think one thing which would be very helpful is if we have some standardized online learning modules with associated assessments, so that at least motivated students have trustworthy resources which they can learn from and then self-assess themselves. I think motivation is a very, very important criteria, you know. The 10% motivated students can do more than the 100% who are sitting there in a forced class. That is one thing that appears at the macro level. Secondly, I think if we can have a assessment bank of what can be, I keep coming back to the word, sneaked into our existing internal assessments at different levels. So if we have an assessment bank, then each unit, each department doesn't have to think up of its own. The third thing is, I think adjunct faculty is a very good idea. Where that is not immediately feasible, one option may be to have someone who can at least give a Zoom talk during that session on cancer pain management and pharmacology. That can be a place to begin. You know, the pharmacology class is happening, Rajgopal sir is speaking for 20 minutes within that. And that may not need the academic board's permission. It may only need the permission of the HOD of that department and the teacher who's taking that class. Then another thought, it's not a roadmap, just random ideas, is like recently JIPMA had a festival on educational videos, a competition. It was organized, I think, by the students. So if we can sponsor a prize where there is a category on palliative care, on communication, or it can be ATCOM plus palliative care. Then Dr. Chitra had mentioned a very, very vital point that those who are teaching palliative care would actually like to learn more practical palliative care. And so again, there's a question of whether we could offer some kind of a travel fellowship for faculty who are willing to start it in their department and want to learn, see some hands-on. It need not be very expensive, but it also adds some, for want of a better word, prestige to the process. Similarly, there could be a thought of having a prize exam for palliative care across all these 6 colleges. And besides the price incentive, there could be the option of that student spending a couple of days in a good palliative care center. So I think broadly what I'm thinking is that for the very motivated ones, have these attractive incentives and resources. And for the not so motivated ones, have basic exams, and think about ways in which we can bring in the adjunct and the networking, if not physically, at least online.
Reena, I thought that was precious. Sridevi, was this a discussion that happened? Am I causing a repetition of some things that were discussed already?
No, sir. First time we are discussing on this.
And you have taken some notes on Reena's precious suggestion?
Yes, sir. Yes.
Okay, thank you. Reena, maybe just putting together, we'll listen to the others now, putting together whatever you said, can we create some sort of a roadmap? Say, for example, a hierarchy starting from the bottom. Dr. Kumar said, no, Dr. Anish said everything has to be practical. It has to be real, not just theory. At the very basic level, teaching videos. Sorry. Sorry for that explosion. So, anywhere, any college can access the videos that all of us together create. We have quite a substantial video bank already. We can build on that. Whatever is available should be available freely to the faculty of any medical college. Do you see any problem in making that happen?
I think that's a great idea. And one thought that struck me is, in addition to videos and role plays which are teaching, if, with permission, we can have a few brief testimonies by patient relatives, by non-medical team members, 5 minutes, 10 minutes about what they do or what they received or what they needed. That I think could be even more impactful than us preaching in some things. And there may be patients' relatives who will be very happy to contribute to the development of palliative care in this way.
And thank you, Reena. And Sri, maybe that will have the videos will have to be annotated. That shouldn't be too hard at all. Every video that we make available is annotated with a few notes and maybe tied to a particular competency that's going to be taught. This is useful for such and such a session. This is some. Thanks, Reena.
Sorry, after you finish, sir. Huh?
I have done.
Yeah, the other thing I found useful when we did a few videos recently is if we also put the questions into the video. A couple of questions, reflective or whatever, and so that's a specific form of annotation, I suppose. Yeah.
So, in the hierarchy of learning aids that we were talking about, the one that can be pretty soon, it shouldn't take long. We have the videos. It's a question of annotating them, putting in the questions. Great idea, Reena, thanks. And making them available, something that we can do almost immediately. And that can be made available to all the institutions. The only difficult part is the advocacy to convey this out to the staff members. It will be difficult to reach all the staff and let them know that this is available. That's the only thing. And most people may not pick it up. That's fine. Still, if some pick them up, that's great. And at the second level, we have invited faculty virtually joining in and interacting with the students. Apart from the teaching videos, no, not only teaching videos, videos of lived experiences also. The second category is faculty appearing virtually. The third category is adjunct faculty, whether officially made adjunct or not, coming in and assisting with teaching, which will be possible only for a much smaller number of institutions. And on the top, of course, is practical learning, certainly in places where there is an access to palliative care. And anybody, I mean, what are your comments about this? Sri, let me ask you. I jumped in suddenly without listening to all the deliberations earlier. Is this the right time for this discussion, or did you have something else on the agenda right now?
Sir, no, this is the right time. We were expecting this discussion this time.
Okay. So maybe please, I have put in, I think, 4 things on the hierarchy. And who would want to comment on this? Please feel free. I mean, if you feel, okay, this is not really doable, certainly we need to know that.
Sir, Sunil here. So just want to make a comment regarding what you have told. So Dr. Deepak, who is in Believers Church Medical College, even though he is not doing this in a systematic manner, he has charted out some topics and the students' presence, and he has also requested my presence during the presentation, so that after that I'm also giving some inputs and there is some discussion happening. So the virtual thing is happening in Believers. So this is something which, as you told, can be, it can actually happen.
Very good. Happy to hear that, Sunil. I didn't know that you were doing this. Kudos to you. Others? Dinesh?
So I would like to re-emphasize Dr. Reena's idea where some online course could be made available to the interested, MOOC-like kind of thing, which somewhere we had discussed and which I barely remember that you told there's some possibility of collaboration with some university where that kind of course could be available, which of course we could promote among the interested students and maybe faculty also. So which could have certain credits, maybe I don't know how it works out, but it could be with credits or without credits. So that I think will be an interesting thing to provide, because definitely, sir, in the large pool of 80,000 students who come in every year, so even we go verse by verse, even if say 1% of the students are interested, then we have 800 people who will get able to do it. So I think that is one thing which is worth trying, sir.
Dinesh, thank you. That doesn't fit into the hierarchy mentioned, but this is something that goes parallel and very good. Dinesh, we have done something about it. Some correspondence going on with Center for Advancing Palliative Care. They are not willing to make it as a free MOOC available to everybody, but they are willing to, we are negotiating with them. We'll see what we can do. Maybe they are not the partners. It may not work out, but whatever, somewhere we must do that. That I think the current issue with the MOOC idea is only with having the platform and whatever we have produced with CAPC already, they are insisting on registration and a sharing of fees, etc. I don't know. We'll continue that negotiation. Yes, Reena.
I had a thought. The National Cancer Grids e-learning platform is free. They have an education person. So even, the modules each of us has prepared, if we just give the content, they may be able to convert it possibly to this thing. And the added advantage is it's not just students, but also practitioners who will be able to access and learn it if they want to. And by philosophy, it is, they have said it has to be free.
Reena, unfortunately, CAPC, after all the hard work, we cannot possibly use it without their permission. So we'll have to negotiate it. If NCG gives it the platform, maybe we'll have to somehow work out the way of making it possible. These things can be done. I mean, conversations have to continue, negotiations have to continue.
Yes, sir. I had a conversation with NCG already a month back. They have agreed to host it as soon as we have the content for free.
Yes. Okay. Let us see what happens now.
Any closing comments? Maybe the last few minutes from any of the participants or the mentors, anyone.
So in the repository that we were discussing, all the modules that we have prepared and all the things, probably they also will be put in for free access, I suppose.
Apart from the CAPC module, okay, Sridevi, any other material that we have created so far can be made freely available, or are you planning to use it only for people who register, even if without a fee? How is it going to be made available? Have you talked about it?
We are, those who are attending, colleges who are attending the faculty development program, we are planning to share all the materials that we have created.
No, I'm not. No, okay, Sridevi, let me clarify.
Yes.
I'm not talking only about the institutions that have attended the program. I mean, I don't know the wisdom. Just making it available itself may consider devalued, because free things are sometimes not respected very much. Do we, Dinesh, I don't know whether that is exactly Dinesh's question, but maybe I am paraphrasing. All the content you said, it will be available for the participants of the workshop. Can they be available to just about everybody from the website, whoever wants to? Points for and against. We need to think about it. Are there any downsides? Is there any downside to it?
Can we take participants' view here? Because we have been discussing this issue for quite some time. Maybe others in the group, pros and cons, they can speak about it.
Somebody, will you please speak up? Participants who have had opinion. I mean, it would be nice if, especially as Dinesh says, we have talked about this for a long time. At some point of time, it's good to arrive at a decision. Dinesh, you have heard, if you have heard the comments, what are the potential negatives?
As you told, I will not perfectly agree that it will be devalued, because it is still a rare resource. Like for anyone who tries to find out quality resource for palliative care training, maybe whatever level of training we are talking about, if it comes with some kind of validation from a NGO like Pallium India, then it will still carry a value, sir. So I'm still perfectly in favor of having it free access to anyone who wants to use it. Maybe with each of these things, as time progresses, we can have small guides also for every resource that we have. Maybe that can be done later. But every resource with one small manual kind of thing or maybe small guide. I think that is one of the things that we should consider. I favor that thing as of now.
If shall we make a note that nobody has a negative comment about free access to everybody? I mean, there may be other problems to be brought up, and we don't have to take the decision at this point. But Sridevi, neither would I want this decision to be postponed indefinitely. Let us say by the end of April, at least, we have a final decision on making all the material available for free access through the website.
Sir, if you're not thinking of all the material, maybe some curated material, which is sufficient enough kind of thing. And beyond that, maybe we can put some kind of training or something they undergo, and then they have access to a slightly larger set of resources.
If you think so, maybe you don't have to answer now, Dinesh, but later, could you please put in writing what you think should be basic and what you should, I mean, some material for somebody with no exposure at all. Could that be actually dangerous? I don't know. I can't think of anything like that. But what do you think will be the basic that is available for everybody? What do you think is advanced for which is only for course participants? Some idea like that will be good. Personally, my instinct is to make available everything free. Where knowledge is free is the dreamland that Tagore sang about.
Yeah, that is where I was.
Suddenly you got muted.
And I think unlike learning to do some very expensive procedure, someone who's actually motivated enough to find this out and learn it and teach it, probably the benefits outweigh the potential problems. That's what I feel, even if it's freely available.
I haven't identified even a single potential problem, actually.
So can I add at this point?
Please. Yes, sir.
Hello.
Yes, sir.
Sir, so I don't know whether I am getting confused or because I lost communication at some point in between. So the idea of integrating palliative care into UG curriculum is the way forward for palliative care. That's the first thing that I feel, because what I feel is palliative care and I'm interested in geriatric care. These are two things that every doctor should know. It should never be an elective. Because, for example, tuberculosis treatment of tuberculosis is taught in MBBS because it is a public health problem. The same way, having access to quality palliative care and geriatric care is a public health problem. So I think the way we started is right. And as about the media being available for free, sir, I don't think it is just because there are no modules available that people don't know about palliative care. It is because they don't have opportunities to hear about it. And it should not be, because I am totally against specialization. It has actually destroyed our profession. We are dealing with organ specific doctors, which itself has become a problem. So palliative care should not fall into that trap. It should not be confined to some specialist. It's not a specialization. It's a skill that every doctor should have. And we have been talking about challenges. I'm very positive about this happening in our institution. And I'm sure at the end of MBBS, at least 2019-20 batch, they will know what palliative care is. Even if they don't know the intricacies of it, maybe the total details of it, at least they will know that who requires palliative care. I think that should be our aim. And to start with, I think we might think that it's impractical, but hearing this one, that is integrating it into curriculum, that is a brilliant idea. Even if we have challenges, we should get over it and make sure that this happens. Even if at least 40% of what we have aimed for, if it is achieved, it's a win-win situation, because I am a graduate who passed out 10 years back. I didn't learn palliative care. I didn't learn geriatrics in my MBBS or in my MD, but I treat these patients every day. So that's a sad part of it. And that's what brings me here. So I think this is a good idea. We should, and about, you can make it free, because all the media that Palliative Media brings out is free, but whether we will be looking into it, that will be a question, because knowledge is everywhere. It's about, and the what motivated student, that should never be used. Nobody should have the motivation for palliative care. Actually, it should be there with them if they have decided to become a healthcare worker. They should know it.
Anish, thank you. Anish, with your permission, I'll keep out the specialization arguments from this subject, specifically because already Russia-Ukraine war is going on. As soon as we bring this up, there is one more fierce war that is closer to home. Actually, it's happening in WhatsApp groups right at the moment. I mean, and passions rise and all our compassion melts away when we bring that up. I acknowledge the importance of the subject, but maybe it's not necessary here. Let us, I mean, because if we bring in contentious issues, we get distracted. But everything else that you mentioned is something that we'll go by. And so, pardon me for escaping from the specialization argument. I have my own opinion about it, and which is not very much different from yours, maybe with some modification, but we'll keep it out with your permission. Then maybe was there somebody else who wanted to speak?
No, sir, I didn't see anyone raising hand, but I think we might wind up discussion because I think it's time for them to leave the college. We have been trapping them for last 5 days, 3 hours. So I am yet to get the feedbacks. So yeah.
Sri, thank you for putting this together, and it has been.
Sorry, sir. Dr. Kannan is raising.
Dr.
Yes,
Kannan,
sir, please.
Can I speak for? Very nice to be a part of this curriculum update, because it was like a homecoming for most of us, because we have met all our old mentors, our old teachers for palliative care, and we are also finding new friends with a lot of good ideas and new ideas coming up. So it will actually help all the 6 institutions to grow together. As somebody had suggested, I think it was Reena ma'am, to keep this going from the Pallium, if we could still have, some sort of an essay competition, some sort of a competition, not among the faculty, among the students. I'm sure, all of us have access to the top level administration, so we can coordinate with our own teams and we can request our students to have some sort of a painting competition, some sort of or photo things, because we do a lot of work during this online. So with the sir's permission and with the Pallium India's permission, if we can have it, then I think this enthusiasm will keep going out of noise.
Dr. Kannan, thank you. Sri, please make a note of that, and we'll talk about it without much delay. I think that's a fabulous idea. We'll pursue that. Thank you.
An essay competition on another topic, so I'd be happy to help with this if you feel it's appropriate.
There you go. Very good. Sri, I don't know what's the appropriate time. Maybe it is good to announce this at World Palliative Care Day or something. If we make some kind of a timetable for the last date for receipt, of the manuscripts, and then the evaluation system, which that's the most difficult part of it, getting people to volunteer to evaluate, and then a marking system, scoring system, etc. And then to be announced on World Palliative Care Day. That would be phenomenal.
Thank you. Thank you.
Dr. Kannan is such a getting photography competition also great. Okay.
Thank you so much, everyone, for, I think I've written 4 or 5 pages. So whenever you put in new suggestions, I'm getting literally tensed here because how am I going to go next? But so I've literally written so many pages. I'll compile everything and I'll share more resources, including the mapping. Someone was mentioning the mapping. And Dr. Anish, to your question, there are a total of 22 modules that comes under palliative care. From the foundation course to internship, we have covered only a few. We have 22 modules ready with all the resources. I'll share all the resources with you all, which has the mapping to the CBME as well as the IMG outcomes. So I'll share that soon. And I'll be keeping on bothering you over the phone or the WhatsApp about what step next. And I'll send a feedback form also tomorrow. I'll compile all the inputs and send it in a single document. And I really want to get genuine feedbacks from you all, because as Dr. Rajgopal mentioned in the beginning, this is all a new beginning, new program for us. So I would like to learn, get proper feedback and improve our future training programs. Thank you so much, everyone, for being with us and all the mentors. Thank you, sir.
Thank you.
Thank you. Thank you, sir.